Really, we're just gonna focus on media today. It's not? No, it's different. It's broken down and more manageable. It's not entirely new information. Ah, there we go. That is the problem. Thank you, Lacey. Okay. Okay, it's 11 o'clock. What time do you guys have PK? 3:30. Awesome. Okay. So 2 pieces of information that are relevant to you. Actually, I'm surprised so many of you showed up today. 1, if you want to go spend this time to study PK, no sweat off my back. I'm recording this. It's 20 slides. We probably won't even be here the whole time. The second piece of information that's relevant to you. I do not feel awesome today. I don't know if you can notice my voice change a little bit. It's a little bit deeper. So if you don't even want to be in a room with a sick lecturing person, by all means, that could be your other motivation to walk out of said room. Again, no judgment. I understand. Go study PK. I will be recording this 20-slide recording of Mania and posting it. This isn't a ton of new information. It's stuff that we probably would have covered last week. And this is under week 11. So like I said, make your choice. And good luck on PK this afternoon. I hope you guys do awesome. Yep. It was fine. I was at the beginning of getting sick, so I was a little disgruntled. No, we decided next year though, I think we're gonna all 3 of us dress up. We're gonna let our son choose, but he was Steve from Minecraft. Yeah. So I think next year I'm gonna, like, if we had done it this year, I would have made, bye Cade. I would have made her dress up like the Jason Momoa character. I think that would have been really funny. Yeah, missed opportunity there. Oh, really?
They would wave them so cute.
Did you get a lot?
Yeah, because we live in a neighborhood with like actual.
Yeah. We were thinking about going to like the England Road behind TJ Maxx and stuff.
Oh,
Yeah. Okay. How's everybody who's still here doing? Good. Tired. Excited for today to be over, probably. Do you guys have anything at the end of this week?
No.
Oh my gosh, so you're telling me that next weekend you can actually enjoy yourself? For once. Okay, well, I think today's lecture should be a good riff off of what you guys covered in med chem, because Aja and I were talking this morning about lithium. And so we'll be discussing that today. Because I am not feeling well, I'm not handing out your name cards because I don't want to touch each and every one of them and hand you this possibly infected card. So we can do 2 tomorrow if we so choose. Yes, Aja and I are going to meet today to kind of discuss, hopefully continuing to line the rest of the semester. Okay, so pharmacotherapy of mania is where we're going today. So we haven't talked a ton about bipolar disorder, so it's probably good that we introduce a little bit of it today. So bipolar disorder is characterized by kind of these swings for between the kind of these 2 symptomologies. I want to say phenotypes, but it sounds so genetic, but more of these 2 symptomologies of both mania and depression. So the mania is characterized, and we'll see on some subsequent slides, kind of different variants of this. The mania is almost reminds me a little bit of like the positive symptoms that you would see of schizophrenia, where you have kind of this talking excessively, racing thoughts, hostility, less sleep, sometimes delusions, and we'll talk a little bit more about delusions. And then in terms of the depression side of bipolar, you have extreme fatigue, prolonged sadness, memory loss, and poor nutrition. Because these are kind of 2 very different symptomologies in the way that they're presenting, we will see some combinatorial therapies that are sometimes utilized. We'll highlight and talk a lot about lithium and kind of its efficacy in treating bipolar, and then also how sometimes treating mood stabilizers are also a very effective pharmacotherapy going forward. This is taken from the DSM. Again, just kind of showing you the depressive end of things, kind of the elevated or irritable mood, and kind of how those kind of fix, and that these can really be gradients on both sides of the spectrum. So keep that in mind as well. They're probably going to present differently and within different people. So if we define mania, again, is a period of elevated, expansive, or irritable mood with coexisting symptoms of increased energy and goal-directed activity and decreased need for sleep, right? And so we'll talk about a little bit, we probably won't get into a ton, in terms of how, because of this, again, increase in goal-directed activity, right? Like that sounds almost like a positive thing, but can lead to kind of this burnout effect in individuals who are going through these manic experiences. And so sometimes getting individuals to adhere to their to the drugs they've been prescribed is sometimes difficult because they're, again, seeing all this increased productivity during these manic states. This, again, just represents one side of the bipolar disorder. And this can be induced, again, not just by this underlying state, but also medications can also induce things like mania. So we've talked a little bit about dopaminergic agonists, antidepressants, stimulants, and again, stimulants almost can also override these substances of what we call substances of abuse, things like cocaine and amphetamines. We've talked a little bit about cocaine in regards to its use as a local anesthetic, and we'll actually probably move into amphetamines and psychostimulants maybe later this week. And so those also can induce things like mania. And then again, although periods of substance-induced mania should not be relied solely to be used to make the diagnosis of bipolar disorder. Obviously, if you do have an individual that you are predicting might be in a substance-induced manic episode, the first thing that you'll want to do is to kind of slowly remove that stimulant from their physiological system. You don't want to do like really quick removals. Again, our physiology isn't great with quick removals of either hyperdepressives or hyperstimulants, right? Because we're used to being on that speed. And so doing a slow tapering is always advantageous in that regard. So keep in mind when we talk about mania, there also are kind of, we'll say lesser, less severe versions of that. Things like hypomania. And this again, generally is not considered a functional impairment. It doesn't require hospitalization, not associated with some of the psychotic symptoms that we see kind of in the higher degrees of mania. Now, when we look at the epidemiology related to bipolar disorder, it's roughly 1% of the population, and then kind of all forms of bipolar disorder kind of get bumped up to about 3 to 5%. So it is fairly prevalent in terms of its distribution. Now, again, hypomania versus mania, I thought that this figure did a pretty good job of kind of breaking those down. Not surprisingly, mania is going to be kind of the more extreme, more severe version. Hypomania is going to be a little less extreme. Usually the episodes for hypomania will last less than 4 days. And then your full manic episode would be more than a week. So some part of the timeline and not just symptomology can also determine what level of mania an individual is experiencing. Now, in terms of pharmacology, all atypical antipsychotics, with some exceptions that we see listed here in red, have indications for acute mania. So this is one of the reasons that we talked, or this lecture was kind of pulled into the antipsychotics lecture, because so many of those drugs are co-utilized for the treatment of mania as well. Doses are titrated rapidly or close to the maximum FDA-approved dose over the first 24 to 72 hours of treatment. So depending on probably how distressed the individual is, how manic they're presenting, you'll probably hit those higher doses of the antipsychotics. And then as symptomology starts to as symptomology starts to reduce, you'll start to kind of slowly and taper those. Now, the clinical response to, again, the atypical antipsychotics would be hopefully decreased psychomotor agitation, decrease in irritability, increase in sleep, reduce or absent delusions, and reduced hallucinations. So again, you're really trying to treat those very high-level manic and maybe psychotic presentations that those patients might be having. Now, when we talk about kind of acute versus chronic treatment of mania, combining an antipsychotic agent and a mood stabilizer is again going to further improve those manic symptoms and reduce the risk of relapse. Recommended duration of treatment after resolution of bipolar mania varies pretty largely. Like there's a lot of differences you might see. But if the symptoms permit, kind of you're gradually going to taper those dosages after roughly 6 months of treatment. And one of the reasons for that being is that you'll just see individuals that present with some metabolic side effects. So you might see increase in weight gain in those individuals. And again, that's probably also going to reduce adherence because of things like weight gain when combined with things like a mood stabilizer. So again, antipsychotics, many of them of which we've discussed last week are going to be kind of part of your treatment strategy. Could be combining them with a mood stabilizer. And when we say mood stabilizer, not necessarily talking about things like SSRIs, although those definitely fall in that category, but we'll further be discussing things like lithium and valproate for their mood stabilizer effects. So here we can see again, you might need to continue the antipsychotic treatment for many months. Again, as we previously said multiple times, the mood stabilizer in the form of lithium or valproic acid preparations can be very helpful. Now, there are some antipsychotics that have been utilized as monotherapies for kind of maintenance dose treatments. Aripiprazole, olanzapine. This particular drug has seen reduction in its prescriptives for this particular indication, just because of all of the metabolic effects that it might have. So you're seeing maybe a little bit more weight gain associated with this or hyperlipidemia. And so that was one of the reasons that you might not see it prescribed as frequently. You also have long-acting risperidone, which again is indicated for a maintenance monotherapy, usually again with those mood stabilizers in patients with bipolar 1. Okay, so just to recap, right? Mania is just kind of one manic spectrum of bipolar disorder in which we have used our antipsychotic drugs for with combination of our mood stabilizers. Now, for the antipsychotic agents, in addition to the ones seen previously on the last slide, clozapine can be beneficial with patients with refractive mania and also as a monotherapy. And certain antipsychotics have efficacy for adjunctive use, olanzapine as a monotherapy. But again, because of the metabolic concerns there, you are not seeing it as commonly prescribed as previously. You can see, again, we've discussed some of the different anticonvulsants. So one reason this is kind of placed at this point in the semester is because we've talked about antipsychotics. We've talked about things like some of these anti-seizure medications. So hopefully this is like maybe the second or third time you're seeing these drugs. And so that's starting to kind of make sense as like how and when you would use these for neuropharmacology. And also we have some that are also used for bipolar maintenance. Again, lamotrigine would be an example of that as well. Now, when we talk about, again, the treatment of mania and for bipolar disorder, we'd be pretty remiss if we did not also include in this discussion the use of lithium. Okay, and so I put something in light blue here, which is probably worth, I'm going to read it out loud because it is that important. No medication has yet been designed to treat the full spectrum of bipolar disorder based on biological hypothesis of the illness. And so therefore, lithium is probably one of the most effective, has one of the greatest efficacy for prophylaxis of future manic and depressive phases of bipolar disorder. And so because of that, this is going to be, again, probably one of the standard components of care for a bipolar individual. Keep in mind, this is a very, in the drug world, kind of old molecule. It was kind of fortuitously identified in 1949 for treatment of mania and approved for this purpose in 1970. Again, we use antipsychotics, we have certain anticonvulsants, but in terms of kind of a standard basis of care, lithium is really going to be kind of, like I said before, a mainstay. But we've talked about lithium before, maybe at the beginning of the semester. What is going to be your concern with lithium? Yes, it has a very narrow therapeutic window or a therapeutic index. And so because of that, we're going to talk a little bit later on about measuring serum concentrations. One reason is for toxicity, the other is for adherence. And so we'll discuss that a little bit later on. But yes, that's definitely, when you hear lithium, that should be one of the first things you think, be like, oof, that's a tough drug because you want to keep it right in that window. Now, lithium, in terms of kind of its structure, and I'm guessing maybe you discussed this a little bit today in MedChem, is an alkali metal. It's the lightest. Therapeutic concentrations have almost no discernible psychotropic effects in individuals without psychiatric symptoms. And so again, if you have an individual who's not presenting with a manic episode, who is, let's say, takes lithium, you're not going to necessarily see these largely adverse side effects unless, again, it's outside of their therapeutic index. It can replace sodium in supporting a single action potential on a nerve cell, but it is not a substrate for the sodium pump and therefore cannot be able to, it's not feasible to maintain those membrane potentials. So again, on the kind of neuron side of things, it does not look too dissimilar from sodium. And so it can kind of interact with some of the same proteins that sodium would be. Now, in terms of its mechanism of action here, man, are we looking at a lot of, we'll say, hypotheses at this point in time, because there's a lot of, because it is such a small molecule, it can get in and interact with a lot of kind of almost independent, we'll say, physiological mechanisms. So if you look at in vitro electrophysiological studies, you can see that lithium facilitates serotonin release. But again, this is in vitro electrophysiology. We're not necessarily looking at kind of an intact human in this case. Lithium augments the effects of antidepressants, possibly in relationship to this 5-HT release that we're seeing here in animal models of depression. Again, that could be due to this desensitizing effect at the 5-HT1B site, and that would be a serotonergic receptor that you're having that effect. It also antagonizes mouse behaviors induced by the administration of selective 5-HT1B agonists. So it looks like with these first kind of 2 points that there's possibly some modulation of the serotonergic system. So just kind of remember that as we move forward, and we'll talk about serotonin as its own synapse moving a little bit later on. You can also see leads to decreased activity of several protein kinases in brain tissue, including PKC. Both lithium valproate inhibit the activity of GSK3 beta, and they also both reduce arachidonic acid turnover in the brain membrane phospholipids. So small molecule, okay, very small, not even a molecule, very small ion. And so because of that, it has the ability to really interact with several different protein targets. So I feel like this is probably not even the full list of how this particular ion can really exert its action. I found this figure not to freak you out, not to make you feel like you have to memorize anything, but just to give you a visual representation of all of the different mechanisms of action that lithium can kind of exert. So you kind of saw the written version of this on the previous slide, and this is more of a pictorial version, just showing you, again, all of the different possible sites of interaction of lithium. Yeah, so it's not a short list. It can affect dopaminergic, norepinephrine, GABA, 5-HT, glutamate neurotransmission via just almost everything that those particular synapses do. So yes, I know this feels a little bit like me waving my hands in the air and saying, we don't know exactly what lithium does, but I feel like that's pretty accurate in terms of like the individuals who study this particular ion as to like exactly where it's exerting its effect. I don't know if we've been able to kind of really hone into which of these mechanisms of action is really exerting the greatest of the therapeutic effects, if that makes sense. Yeah, it's just really hard when you have something that is this small. Now, with that in taking this into account, keep in mind, again, because of that narrow therapeutic index, we are going to be concerned with things like lithium toxicity. So neurotransmitter imbalances can lead to a lot of different types of presentations of symptomologies. So when we look at some of the adverse effects of lithium, you've got CNS effects, renal effects, thyroid and endocrine effects, ECG effects, skin effects, pregnancy and lactation. Like if we look at some of the side effects kind of listed here, again, you'll see increase in urination, thirsty and tremors, maybe hair thinning or hypothyroidism, interactions, upset stomach, muscle weakness, even acne and psoriasis pop up as possible adverse effects that you would have patients. Again, if they're taking lithium to maintain or to treat their bipolar disorder, these would just be things that you'd probably be consistently kind of checking in with your patient about. Now, you obviously can have them report out symptomologies related to some of these adverse effects. Other ways in which you could monitor, again, both adherence and if they're falling into kind of the toxic level, would be to do serum level monitoring for dosage. Because again, that low therapeutic index, regular determination of serum concentrations is going to be crucial. you can see roughly kind of the serum concentrations that are reported here. I consider this to be a little bit more under the realm of therapeutics. So I won't be asking you to memorize said serum concentrations of lithium, but I just like to plant the seed now as to kind of its importance and kind of just rough numbers in case you're really interested in neuropharm. Usually the serum concentrations will be measured 10 to 12 hours after the last oral dose of lithium for the day. And individualization of the serum levels is necessary to kind of, again, obtain that risk-benefit relationship. Is this current dosage of lithium reducing some of their symptomologies related to their bipolar? And are they also reporting maybe high levels of some of the adverse effects that we saw in the previous slide? Now, in terms of kind of what happens, what kind of symptomologies and what things outside of some of those other adverse effects that we saw previously reported, what does lithium toxicity look like? Well, you can see you'll with the serum concentrations, you'll be observing both lithium and its rate of rise following administration. Acute intoxication is going to appear as things like vomiting, profuse diarrhea, coarse tremor, ataxia, can go as far as things like coma and convulsions. So again, it's important to recognize when patients maybe even come into the ER, you get a full, understanding of what prescriptives they're taking, because if they're presenting like this can look like a lot of different things, right? And so doing that serum concentration can be really important as to informing if lithium toxicity is something to be taken concern. Symptoms of mild toxicity are likely occur at the absorptive peak of lithium, and again includes nausea, vomiting, and abdominal pain. If we go into kind of more the serious side effects related to the nervous system, mental confusion, hyperreflexia, gross tremor, dysarthria, seizures, you'll start to also observe maybe some cranial nerve and focal neurological signs. And then eventually you'll start to see things like progression to coma as well as death. Now, in terms of treatment for lithium intoxication, we don't necessarily have kind of a tried and true pharmacological, because of all of those different mechanisms of action. It would be really difficult to design something that could mitigate its interaction with its target's proteins. And so because of that, most of the toxicity treatment is just supportive care, intubation, indicated of continuous kind of cardiac monitoring. Depending on the severity and the types of symptomology, you would probably just most likely support their physiological systems until lithium is able to be metabolized and kind of work its way through the system. So yeah, much like we saw with with benzodiazepines, we have this like nice pharmacological target that we can use to mitigate that type of intoxication. But in this case, it's interacting with so many different proteins, we don't have a single kind of antidote or way to kind of treat this type level of intoxication. Okay, questions? Yes, no. Of lithium? Yeah, so it's gonna be metabolized through the renal system, but in terms of like the half-life, I don't know exactly. That's a great question. Like, I'm not sure what the half-life for lithium is and how quickly it works its way through our system. Anybody want to do a quick Google? What is our half-life of lithium? We're gonna have plenty of time. We're on slide 15 of 20, so you will probably be out of here shortly. Yeah. Half-life of lithium.
18 to 36 hours.
Yeah.
18 to
depends on
36 hours.
Adults or kids, pediatrics was 27 hours and 18.
Oh, wow.
And elderly is like 29.
Elderly is 20. Okay. So an age-dependent elimination factor, it sounds like. Yeah. Wow. That's intense.
And it's the proximal tubules that.
Yeah, that makes sense. Yeah, that makes sense, because we will talk about some interactions with other drug types, and those also act at that same within the renal system. Do you find that helpful, Noah? Okay, good. Okay, so yeah, other kind of treatments, combinatorial or not. Again, when we discuss this, lithium valproate and carbamazepine, again, it does have efficacy in acute mania, and they're usually combined with kind of an atypical antipsychotic drug. You see that again, just because they do have complementary modes of action, but don't necessarily like directly hit kind of the same exact mechanism of action. Are effective only with daily dosing that maintains adequate serum levels, and again, requires the monitoring of serum levels, especially if lithium is part of that kind of panoplia of drugs that those individuals are taking. Now, sodium valproate provides anti-manic effects, is considered kind of a mood stabilizer by what we're discussing here. Both sodium valproate and lithium fall within that category. And the most common form of this is going to be the divalproic sodium due to lower rate of incidence of GI and other adverse effects. And then carbamazepine, again, will also be effective for acute mania. The immediate release forms cannot be loaded or rapidly titrated over 24 hours due to the development of adverse effects, such as dizziness or ataxia within that therapeutic range. And so just keep in mind that you also have some concern with things like fatal skin reactions as well, depending on kind of some of the background genetics of particular individuals. So again, if you do see, let's say, a skin reaction that does occur with somebody who's been taking carbamazepine, you probably would want to follow that up with some type of genetic screening to see if they were a carrier for this specific allele, so that can be part of their profile moving forward, and they won't be prescribed or dispensed that particular medication again. Okay, so there is a pretty high occurrence rate in terms of the mania associated with bipolar, and there is a high risk of suicidality. Only lithium has consistently been shown to reduce the risk of suicide compared to other treatments. Now, I'm just going to go back really quickly here. This table was taken from a review article that was comparing lithium with antipsychotics. And you can see the years that these studies were conducted were actually quite a while ago. But in terms of kind of responsiveness, we can see almost 90% of patients with acute mania responded to lithium. And then you had roughly, 10% that were non-responders. And then if you look at the category of antipsychotics, you get kind of almost like an even 50-50 distribution. Not that I'm sitting up here trying to push lithium. Again, there's probably been a lot more recent research gone into the more atypical and more current antipsychotics now, but it's pretty impressive, I think, in terms of kind of the efficacy of lithium to treat it, even, at that point in time. Individuals who experience mania have 80 to 90% lifetime risk of subsequent manic episodes. And as we see with schizophrenia, lack of insight, poor psychosocial support, substance abuse, all interfere with treatment adherence. And again, often individuals think of their manic episodes as being maybe some of their most productive as part of that swing in that bipolar disorder. So again, adherence sometimes is really difficult with those individuals. Drug interactions. So I'm glad that we just talked about metabolism a little bit, because so many of these drug interactions that we see here are kind of a result of that. So we have not talked about these first two drug categories yet. These are going to be a part of our antihypertensives. And so our thiazide diuretics, because antihypertensives are pretty prevalent, you guys have probably dispensed a lot of them, and maybe even discussed some of their mechanisms of action previously. But thiazide diuretics do cause significant reductions in lithium clearance and can result in toxic levels. So anything that affects the elimination of lithium obviously is going to alter kind of that therapeutic window, and that narrow therapeutic window, the window that we just discussed. So this is something definitely to keep in mind when you have an individual who's both hypertensive and is taking, let's say, this bipolar agent. And then just to kind of make it more complex, we just discussed all of the metabolic side effects that are also the result of some of the antipsychotics, right? And so I think it can be a really difficult disease state to treat because of that. The potassium-sparing diuretics have a more modest effect on the excretion of specifically lithium. So again, you're not going to see as maybe much effect on those serum levels. And then if we also, not all, some of the steroidal anti-inflammatories can also facilitate this reabsorption of lithium. And so that would also increase serum concentrations, kind of shifting that therapeutic window once again. So these are just, again, ivermectin. Methicillin is going to be one particular drug to kind of keep an eye out, but also ibuprofen, naproxen, and kind of COX-2 inhibitors, possibly less so with the Silicodec and aspirin. So we do have some pretty commonly taken over-the-counter medications that can also, let's say, alter lithium clearance. So yeah, that's just, if you have anything that affects renal function, you're probably also going to be maybe altering lithium clearance, and that can obviously have some pretty some pretty significant effects on lithium. Okay. Other questions? Okay. So I don't know if it was last year or maybe the year before, we were talking about these two different kind of syndromes that can pop up when you are modulating kind of both dopaminergic or the serotonergic system. So this is kind of, we'll say, independent of the very specific mania discussion we were just having, but this is more focused kind of on more broadly the antipsychotics. And so on some of the antipsychotic slides, there was some noting of neuroleptic malignant syndrome, which is called NMS. The cause is associated with the use of antipsychotic medications, particularly those typical ones that lead to dopamine receptor blockade. Now, the way this presents is going to be with hyperthermia, muscle rigidity, altered mental status, and autonomic dysregulation. So you can see here a series of other measures that could also be altered. This does develop pretty slowly over 1 day to 2 weeks after the initial dose and the dose increase of those neuroleptics. And the treatment for this is going to be immediate cessation of said neuroleptic, aggressive supportive care, potentially medications like, again, bromocriptine, the benzodiazepines, just kind of depending on how significant this NMS is. So yes, when we were discussing antipsychotics, we talked a little bit, briefly mentioned neuroleptic malignant syndrome, but really didn't describe exactly what it was. So again, this is due to dopamine receptor blockade. Again, there's a lot of different ways in which it can present. But interestingly, it sometimes is mistaken for things like serotonin syndrome, which we have not discussed yet because we have not talked about serotonin. But it is something that also can occur with some of the drug types that we'll be discussing in the future, specifically things like SSRIs, as well as MAOIs. And we'll talk about why those two things should never be prescribed together because of their mechanisms of action. But the serotonin syndrome is kind of this excessive accumulation of serotonin triggered by a use or overdose of serotonin enhancing medications. So SSRIs obviously increase the amount of serotonin within the synapse. So again, if somebody's taking an SSRI and also maybe taking psychotropic mushrooms, which also tend to hit 5-HT2A receptors, probably not a great mix. But the symptoms, again, you have a triad of cognitive and autonomic and neuromuscular presentations. Again, confusion, agitation of the cognitive system. With autonomic, you see hyperthermia, which also, again, is a symptom that's presented during LMS, and tachycardia, which is also, again, a symptom that we see presented with NMS. But where these two things differentiate is that serotonin syndrome is usually a very rapid development. So if you have somebody who comes into the ER and is presenting with, let's say, a hypothermic tachycardic state, and they have, again, some altered mental status, like just that brief description I gave you there, could possibly be either one of these disease states. Okay, so this is one of the reasons that you probably would start to get maybe more of a, you would look at their medication list, see what they're being prescribed. Are they getting prescribed an antipsychotic or are they prescribed an SSRI? Right, that right there will tell you a lot of information. But also the time of onset will also help you differentially diagnose these two things. This serotonin syndrome, very rapid onset, usually with hours of that medication change, versus if this person has been taking their antipsychotics or just shifted an antipsychotic in the last, like, let's say 3 weeks, 2 weeks, that would be much more of the slow onset you would see here. In the case of serotonin syndrome, you're going to discontinue those agents, maybe get some supportive care, again, just kind of depending on how intense that is. Why they are confused again? Because they do present with similar symptoms, hyperthermia, altered status, autonomic instability. Both, again, are associated with psychotropic medications, whether it be a serotonergic modulating one or a dopaminergic modulating one. Again, the way you can differentially diagnose is usually that onset of time. And then the neuromuscular symptoms can also be an indicator, where serotonin syndrome often shows hyperreflexia and clonus, where NMS is usually characterized by muscle rigidity and bradyreflexia. So if you're doing kind of, again, a full diagnostic neurological workup, and you were assessing their neuromuscular junction, those would also present slightly differently as well. So I know you guys are probably like, man, the differential diagnosis kind of came out of nowhere. That was kind of prompted by a question that we had in class maybe last year, but still relevant nonetheless. We will talk more about serotonin syndrome when we talk about the uses of SSRIs and specifically MAOIs. That's where we tend to kind of really get concerned about it. But silver lining, that's it. That's all I have for you today. Does anybody have any questions? Today was kind of just a quick one-off lecture about mania. Really try to keep it focused in terms of these are the symptoms, these are our prescriptives, these are some of the common themes that we see associated with said prescriptives. But does anybody have any questions before I let you go? Besides, what are all the answers to the PK exam? I do not have that information. This will be on exam 4. This, yes. So anything from, from here on out will be on exam 4. Like I said, I'll be meeting up with Aja later today. I would like for us next to do psychostimulants. So that's probably what Tuesday and Wednesday will look like. And then we'll start to move into antidepressants. Hopefully we'll soon be getting through a lot of neuropharmacology. We'll have a couple one-off. We also have pain, opioids that we need to cover as well, which are kind of extensions of that. Okay, thanks for hanging out. Thanks for your attention. Good luck on your exam. If you have anything else that you need at this time, feel free to reach out. Otherwise, see you later. See, Alish, I should just have you basically do case conference presentations in this class. That's awesome. And not awesome that that happened, but interesting nonetheless. Stabilizing AP by reducing them. Yeah, probably. Okay. I'm talking to myself.